good afternoon.
Good afternoon.
I'm hoping you're not too hungry and that I will be interesting enough to keep you awake over your lunch break. My name is Rosemarie Gachie-Lopokoiyit, like he said. I'm the National Secretary of Kenya Paediatric Association. I'm also a pediatrician practicing in one of the private hospitals in Nairobi, which has done a lot of work in terms of disasters and pediatrics in disaster. So we're going to be talking about partnerships in supporting child health. Can you all hear me? Okay, I tend to talk a bit fast when I'm nervous, so if I'm talking too fast, you can please tell me to slow down. So just to give you a bit of background about Kenya, I've seen many of you have actually traveled to Africa and you probably have some of this information. It's quite a small country, just a bit over 224,000 square miles. A bit smaller than the state of Texas, with a population approximately around 50 million. If you look at our population distribution, we have quite a young population. In terms of life expectancy, for men it's around 64 years, for women 68 years. What is Kenya famous for? Of course, we're famous for the Great Migration. We're famous for our athletes. I don't know how many of you watched the Berlin Marathon. Our Kenyan athlete actually broke the world record for the marathon. Famous for our beaches, beautiful beaches, our beer, our Maasais. We have lots of different cultures in Kenya. And now we're globally famous for M-Pesa. M-Pesa is a money app that allows you to have money on your phone. So you can send money to anyone across the country, you can receive money, and you can also pay for services. So, like I said, 50 million people with 44 million mobile subscriptions. So even in very rural areas, people will have access to mobile phones. And this is a sculpture in one of the malls where you can see him fully dressed in the Maasai gear and still on his laptop. Talking about our Kenyan statistics in terms of health, if you look at this data is from our Kenya Demographic Health Survey, the last one having been carried out in 2014. So between 2003 and 2014, we have made great strides in addressing under 5 mortality. You can see it's gone down by about 50%. When you look at neonatal mortality though, we're still not doing as well as we would like. It's still decreasing at a slightly slower rate. Our current neonatal mortality is 22 per 1,000 live births. In terms of nutritional status, wasting we're not doing too badly, but 1 in 4 children in Kenya is actually stunted. What are the kind of diseases that are affecting us? Of course, things that affect sub-Saharan Africa, pneumonia, diarrheal diseases, and neonatal diseases contribute for just about a third. So Kenya has now gone for a devolved system of government. And the idea was to bring resources closer to the people. Health was also devolved. However, how it was done, it was kind of done in a very rushed way and in a haphazard manner. And health is a very complicated issue to devolve. So this resulted in a lot of disgruntled health workers, and last year we had several strikes, and some of them were quite prolonged because the issues were not addressed. And just looking at the impact, if you look at the number of children vaccinated in 2017 compared to 2018, there was quite a dip. And then now, it went on for around 5 months. So you can imagine those primary vaccinations, which start at birth, go on until 14 weeks. There's a whole big gap of children that missed out on those vaccines. So now we are struggling to catch up with that. Our health system is also, we have the public facilities and we have the private facilities. So the public facilities go from the health dispensary all the way up to the referral hospitals. We have 2 referral hospitals, one in Nairobi, one in Eldoret, and then the other facilities are spread around the country. In terms of private facilities, we have a lot of inequality. So this is one of the private health facilities in one of the slums, and this is where I work at Mpisha Hospital. We've recently now opened a branch in one of the high-end malls in Nairobi. So in terms of our organization, just to give you a bit of history of where we've come from. This year we are celebrating 50 years as the Kenya Paediatric Association. started in 1968. It was literally a handful of pediatricians, so maybe around 5 pediatricians who came together, and they were the only trained specialists in pediatrics at the time. And the purpose of the association was to provide professional support and then to continue giving them clinical information to handle new and emerging diseases. Since then, we have grown in number. We have over 500 members across the country, although I must say not all of them are very active. Kenya Paediatric Association generally is an association whose principal members are pediatricians practicing in Kenya, and now lots of other cadres of health workers who are associate members. We are non-profit and non-partisan. Our mission is to be the guide and leader in comprehensive child healthcare delivery through promotion of best practice in pediatric training, research, policy formulation, and capacity building of members. And our vision is to provide an optimal healthcare environment for children. Our motto basically is Afya ya watoto wetu, which means the health of our children. And those are our core values. Now, it became apparent that we needed a body that would handle the grants, manage the funds that were coming in for various projects. And so we have Kenya Paediatric Research Consortium that was formed as an independent research arm of Kenya Paediatric Association. So it helps to support the association in scientific activities outside the realm of a civil society organization, and it leverages for KPA in engagements with relevant government departments. So this year we also developed the second strategic plan for the organization, which will guide us for the next 5 years from 2018 to 2022. 5 strategic pillars were identified as being very important to us. The first is the College of Pediatrics, and I'll talk more about each of them. Institutional capacity building and resource mobilization. In terms of how we raise funds for the organization to run our activities, very little comes from membership fees. So our membership fees are only 3,000 shillings, which is like $30. And out of those 500 members, we have the highest paid up membership this year, which is 200. So it's quite a small amount. It doesn't really contribute much. So this was quite important for us. How do we build capacity? How do we become financially independent? There's also membership, research, and advocacy. So KPA has become a leader in the region and continues to be so. And part of the issues that have contributed to its success is the creation of a permanent secretariat. In the early 2000s, so KPA is a volunteer organization. So even the executive, the volunteer positions, people have full-time jobs. So the agenda of KPA was really run in people's free time. But now we have a 3-staff secretariat who are able to continue the work, and then the executive just guides them in terms of the direction. We also have a very cross-sectional nature of membership. Our members really do play 2 roles, so in their job and as a member of KPA. So we work very closely with the Ministry of Health. The heads of the departments are our members, and they work there, so they're able to help us pushing our agendas with the World Health Organization and other organizations like that. And we have defined structured relationships with government and other partners like UNICEF, WHO, and also pharma, which also contributes to the organization. So recently, this year, polio type 2 was detected in the sewers of Nairobi in routine surveillance. The government had to have a response, and so they had these supplementary immunization activities, and they were having a monthly campaign. So the first 2 that happened coincided with our cold season. And as a result of that, there were a lot of children who were getting sick, and people related that sickness to the vaccine. The pediatricians also were not really quite aware of what was happening, what was the plan for the vaccine campaign, and so they were not giving it adequate support. So when people went to their pediatricians, the pediatricians were saying there's no need to participate in the campaign. So the Ministry of Health approached us as Kenya Paediatric Association, and we were able now to come up with a scientific meeting, which is shown here, vaccination campaigns and the clinician debunking the myths. So the head of their vaccine department was able to come and tell us what is the goal, talk about polio eradication and what is the pathway, so that we could all get buy-in from our pediatricians so that they can help spread a common message. They also gave us a small budget to conduct a social media campaign, which is to create awareness and to inform patients as well as pediatricians all about polio and the benefits of the campaign. So if you go to our Facebook page, you'll be able to see some of the posts that are there, and it's still ongoing. Guidelines, KPA has been very actively involved. These are the two major guidelines that I would talk about, but I'll invite Kiruja later to maybe say a little bit more about it. The basic pediatric protocols are an adaptation of the WHO Hospital Care for Children. If you've seen the book Hospital Care for Children, it's quite a fat book and contains a lot of information. So we were able to adapt it and summarize it into our basic pediatric protocols, which are used in all government institutions around the country. Then recently we also launched the Newborn Care Handbook. A lot of members were involved in that. And both are for use in relatively resource-limited settings. Training and research. Now, ETAT Plus is a translation of the basic pediatric protocols from the book into practice. And I won't say too much because Kiruja will also talk about it. Other areas, we've done a lot in HIV training, IMCI, and most of these have been run through Capricorn. This is just a list of some of the training and research projects that have gone on. You can see some of our major partners include Rotary, CDC, CHAI. We also do a lot of work with RCPCH in the UK. They've helped us to develop an online module of ETAT because initially ETAT was quite labor intensive. It required people to sit in classrooms for a number of days and then get the training. So now they do an online module. It allows us to have a very short duration of actual contact time in the classroom and focus on teaching the skills. And then we've done a lot of work with AAP also. Last year, 2 years ago, they had a big workshop on NCD training in terms of advocacy. And now we are doing a lot of work with them in terms of adolescent health. In Kenya, adolescent health hadn't really been addressed as an issue, but now we are starting to give it more focus. So this is Pediatrics in Disaster. This was the first training course. Do you see somebody familiar here? So far, we've had participants from 23 institutions. And let me just say a bit more about the hospital where I work. 3 years ago, we had a terrorist incident at one of our shopping malls called Westgate, where people came and they opened fire. Over 200 people. There were over 200 casualties with 67 mortalities. So because of proximity, MP Shah Hospital was the first one to receive casualties. And they were soon very overwhelmed. So many of the casualties who died probably died because they were not able to be helped because our system was overwhelmed very quickly. I would say even after the first 6 casualties because of the size of the hospital. So because of that, mass casualty management is actually something quite close to the hospital's heart, I would say. And we've developed quite a robust disaster preparedness policy. We conduct MCI drills. And actually just a week before I came here, we had a drill at the new clinic that we have opened in collaboration with the U.S. Embassy because now it's very close to the U.S. Embassy. So this is just some of the highlights. August 2014, we started the collaboration. In December 2015, the Ministry of Health officially recognized pediatrics training. At the last training that we did, we had contributions from the National Disaster Management Unit. The head actually came and he was able to give his input, which was very nice. And he gave us his personal mobile number, so anything to do with disaster, we're able to get that access. So 92 participants from 23 institutions have been trained. And like I said, MP Shah Hospital had 35 of its senior management team actually go through a hospital incident command system training last year, of which I participated in. Now, talking about our annual scientific conference, this comes under the membership. This is our biggest annual event, and every year we are growing bigger and bigger. So this year we had a total of over 550 participants in our main conference. And our pre-congress is also growing very big. So we have several tracks going on at the same time, and all of them are pretty well attended. This is just an example of some of the sessions that we had. And our theme was aligning child health to sustainable development goals. So like I said, we were also celebrating 50 years. So we had a nice big gala dinner. And at the gala dinner, we also launched our strategic plan. This is the date for our next scientific conference next year, which is in Mombasa, a very beautiful place. I'm inviting all of you to come. The theme of the conference is Beyond Child Survival, a holistic approach to child health. So it would be nice to see some of you there. We have CMEs regularly and symposia, which are either half-day or full-day symposia. The symposia are at a minimum quarterly, and the CMEs are held monthly. Last year, we started our online CMEs. So we did our batch of first 6, and the next 6 are ready to go. And we've just finished recording a 4-part series for pediatrics in disaster. And what we're trying to do now is to see how we can collaborate with regional associations to let them participate and also get CPD points. So this is linked to our CPD provider, and the points go automatically to the medical board. When it comes to advocacy, to raise awareness and directly engage with the decision makers to influence decisions and prompt action on issues affecting Kenyan children and adolescents. So that's what is driving us. Kenya Paediatric Association has actually done a lot in terms of local and international advocacy. A lot of our members are involved in technical working groups that advocate for different issues in child health. We've engaged with media to update the public on areas of policy, governance, vaccines. A lot of the work that Professor Were and his colleagues did helped to add vaccines like the pneumococcal vaccine, rotavirus vaccine onto our extended program of immunization. So they've done a lot of work. This is some of the child health policy issues that we're involved in. I guess I wouldn't say too much more about that. Something else that we have is a pediatric support group. So on Telegram, once people become members, especially after they finish their postgraduate training, they are added to the pediatric support group if they would like. So we have members literally all over the country, across the 47 counties. And we have subspecialists, and generally there's that camaraderie and willingness to assist. So anybody who has a pressing pediatric issue and they needed to consult, they can consult on this forum. People give their opinions, and we're also able to link them to other people who can assist. This was just a picture to show you that the basic pediatric protocols are being revised, and we were getting people's opinions, and they were just adding whatever needs to tweak the pediatric protocols. So you can see there are 236 members right now. And then just to talk briefly about the College of Pediatrics. So it's still in the conceptual stage, and we are hoping that it will provide a sense of identity and belonging and improve the profile of pediatricians. But what we are trying to target is to promote national policy development for professional registration and regulation, and to set standards of training in pediatrics and child health. Right now we have 3 schools training in pediatrics for postgraduate training. They all have their own system, and there's no way to ensure standards. And every few years, there are more schools that are coming up. Right now, the number of medical schools, how many do we have now? I think we have 8 medical schools. So they've grown quite rapidly, and I'm sure a lot of them will introduce postgraduate training. So how do we ensure proper standards? So this is a picture of my daughter looking into the future. What do we want for KPA? So we really want to be the organization that people go to for all things child health, not just in Kenya, but in the region. And for us, college is really core to achieving that. And we are looking to expand collaboration networks. I had somebody here, he's saying, you work in Kisii, you said, in scope? So I wasn't aware of that, and it's a very good resource to have. So expanding our networks and seeing how do we drive our child health agenda. So right now I'd like to invite Kiruja just to talk a bit about ETAT Plus and other in terms of impact.
Thank you, Rosie. So good afternoon. Yes, I'm the training manager ETAT Plus training program, but I also find that I also coordinate and manage other training projects within Kenya Paediatric Association, and also projects which come through Capricorn, the research arm of KPA. So the training that I've spent most of the time with is ETAT Plus. ETAT is a WHO training, Emergency Triage, Assessment and Treatment, which was continuation of IMCI, because IMCI is for outpatient, and you're told to detect a danger sign and refer the child. But there was no preparation where you're referring to. So ETAT becomes the next phase of IMCI, or the inpatient. We used to also call it inpatient IMCI. So what I do, we have gotten funding from different partners. Some 1 training, 2 trainings, much larger trainings. So what we usually do is to make best use of the resources we get. Those who have been involved in trainings in mostly East Africa. So we don't train in hotels, that's one. So that cuts the cost of training. Then we don't give any allowance or per diem to participants. And no one has ever walked us out on us because of that, because we offer very good, well-prepared package of training. We get a lot of support from KEMRI. It's one of the research bodies of the Ministry of Health. So we prepare a well-thought-out package of training material. And it has built a good reputation over time. And one of the private hospitals advertised, when they were advertising for openings, they indicated there that ETAT Plus training is an added advantage. So, and that was also quite, really made people demand to be trained. And also that people could not demand, there was no reason to demand any allowance to be trained. And the demand for training really went high. And we have now hospitals which fund their own trainings. So I just coordinate the trainings. The training also has a bit of quality improvement. So if you do a 5-day training, the afternoon of the 4th day on a Thursday, because the Friday is mostly assessment, because it's a pass or fail training. You have to achieve a certain mark, 50%, and the exam is not usually easy. So on the 5-day training, one of the days we have a checklist to check what you have been training, if those resources are available in the hospital. And it's usually quite nice to go and see that in the checklist it said that, because you give a report to the hospital management team that this basic equipment is lacking, and they give a plan of how to keep or how to get the resources which are missing. Some of them are, like we went to a hospital where there was one warmer or room heater in the newborn unit. And one of the administrators said that he had procured 3 in a few weeks ago. And it found out they were in a store somewhere. And the people on the ones who were supposed to use it didn't know that it was bought and it was within the hospital. Yeah, so such solutions really empowers, encourages us to continue with the quality improvement arm of the training. So that we really need to check that we've taught you how to keep the baby warm. Then are you able to get a room warmer? And if not, some hospitals have some resources. So it's not something which is beyond them to buy or get. So then the other one was one of the hospitals we went to in a place called Kitale. So they didn't have a triage system. So you could, if somebody felt a baby was very sick, usually a clinic officer in the outpatient, they could rush the baby to the pediatric ward, which was quite a distance away. And that also had gaps, and it could lead to the baby's condition worsening. So before we left the hospital, they had already started a triage system. Was it just having a room with one clinician and a few items where they could stabilize the baby before rushing them to the pediatric ward, which was quite far. Yeah, so such stories have really encouraging us to continue training. The content is reviewed on quite often, sometimes even the same year. We can have the content reviewed because of the Ministry of Health work and the Kenya Medical Research Institute, and they are able to keep updating. And the ministry usually print for us the pediatric protocol. And KPA was also able to sponsor an app. Unfortunately, it's only available on Android, which is not a big problem in Kenya, because getting it on App Store required some special licensing because it has drug formulas, and you can't do drug formulas on App Store if you're not a pharmaceutical company. Yeah, so that we are only on Android. So, and we are able to check the downloads. I think we are now at 5,000. Yeah, so it's really been used. Yeah, so it's Kenya Pediatric Protocols. It also has a calculator for dosages on it. So yeah, it's also been quite used. Now we are getting into gaming. So we are having the first game that we're developing is on newborn resuscitation. So we are starting to pilot on it and check how it can be used to improve delivery of care. As you see now, neonatal mortality has not changed much, and mostly due to issues at the time of birth. So yeah, we are doing, so it's now trying to scale the training, because having a one-on-one training is limiting, because we have 47 counties, maybe each 47 county has like 10 hospitals. So getting to each hospital is difficult. So it's now trying to spread the guidelines through other means, through technology and also through the online platform, but you still do the face-to-face trainings. Yeah, so I think, so that's what I do mostly. I run the training programs. I have a pool of about 200 instructors, pediatricians, medical officers, nurses, and clinic officers. So we train mixed groups. So we train everyone together, and the team that trains is also mixed to enhance the buy-in and the teamwork in the hospitals. So some hospitals are still quite hierarchical. So we also want to break in the boundaries and share the knowledge. Yeah. So maybe there'll be any other question here. But Dan has commented on the disaster training.
Thank you, Jason. Thank you, Rosie. I think we can, so in terms of disaster, you can look at, so for example, Joe, it's 1 p.m. and you have a red bus with 50 children, just outside Target, Stapleton, stop. And you have someone who comes in with a rifle and opens fire, and it automatically becomes a disaster scenario. So what would happen in the first 5 minutes?
In our system,
Yes.
we would worry about security with lockdown of our facility. We would then prepare to deal with kind of a surge of patients, which would be many typical bolus of patients. So we would empty our emergency department with a policy we have. We would then determine kind of the numbers and activate a tiered response of call-ins for associated emergency providers, surgeons, preparing OR rooms, blood banks, labs. And then we would triage and start care. So we activate our incident command system in the hospital also, although that usually takes a little while to get rolling. And it would help with kind of the ongoing plans after that.
Sorry to put you on point. I think it seemed like you had taken lunch, so you are prepared to handle it. I know you'll harass me later about this. Yeah. But just looking at what Joe has mentioned, the different levels of preparedness, obviously, they're well thought out way before time, true? And that's a challenge of heart, right from the 1988 US Embassy bombing in Nairobi, which almost everyone heard about, concurrently in Tanzania. And after that, the largest hospital where Kiruja works was overwhelmed, because at that point in time, all the victims, all the injured patients were taken to Kenyatta. And they were heavily overwhelmed. There was no system in place. And at that point, we realized we needed to do something. What to do was a challenge. And as you know, the challenges that we have had, as Rosie had mentioned, is preparedness and putting resources in place to be able to have that discussion. There have been policy documents, but they just remain in the shelf, because you have to be able to have resources available to be able to implement whatever you've planned. And that's now where we have come in. And we realized the response on such disaster situations was more for the adults, and many times people didn't know what to do with the children. As Rosie mentioned, one of the large malls had a similar scenario. Several crazy people from Somalia went in and attacked the mall. And it was coincidental that there was a child-friendly occasion, some fair which was happening. So we had many children in the mall. And people didn't know how to handle it. And the hospital didn't know how to handle it. And you realize, just looking back at our medical schools, we have been taught from a long time ago to be able to respond from within. And even from within a particular department. So you're working in the emergency department and you have several patients who are involved in a road traffic accident. And they come in and you know what to do. Okay, maybe if there are 5 of them, but if there are 10, then you become overwhelmed. But if you get to a scenario where now you need the health workers who are very comfortable in their hospitals to get out and assist, now you remove them from their comfort zone. And that's where we saw a gap. And it was around the same time in 2014 now when we began talking with Steve and seeing how can we meet that gap. Because he didn't have the tools to be able to equip the students, the doctors, the nurses in the hospitals. And this is what we have been doing over time, slowly working through and trying to let the management of the hospitals understand that this is a need. So if we are prepared to get out of your comfort zone and, as a hospital and go out and reach an area where there's a disaster, in a sense, what you're saying is you are ready as a hospital to respond. Because you know what you're going to do at the disaster scene or disaster site. And while you're there, you're able to prepare your colleagues who are in the hospital to know what to do. Because what used to happen was that you just wait and a few people would be in communication with those at the disaster site. And the ambulances would just keep coming in, one after another. And that collaboration between one hospital and another was not there. And this is what you're aiming to do. It has not been easy, as Steve had mentioned in some forums before. Getting people to understand the need to put in resources way ahead of time is something which is a hard task in itself. But Mpisha Hospital is a good example where the management bought into this and they have had some good strides. It has become a center of excellence to be able to invite medics, doctors, nurses from other hospitals around to come in and to be trained. And the aim is such that once Mpisha is well established in the disaster preparedness, then they'll go out and mentor other hospitals and other teams. So that if you have a large disaster in a certain area, you can mention, for example, now the Stapleton area or Northfield or somewhere, then you can have multiple hospitals responding at the same time. Because you have been having these conversations. You have had one hospital which has been playing a key role in empowering the rest. So not only do you have the skills, do you speak the same language, but you have the communication. And that has been happening over time. So in July of this year, finally now we got the disaster policy document for school response, recognized by the government. This has taken a long time. Because we are feeling there's been a big gap in the schools. There's been drought, famine, related floods, and also cases where there's infighting between communities, and then you have displacement of large families. And then, so you can imagine what happens to the children. They leave school, and they leave school for months. And they go and meet in a certain area, and life has to continue at that point. So this has been a big challenge here. So what you're trying to do is to see how we can work with the existing hospitals to be able to reach out through the Ministry of Health and Ministry of Education into the schools and to be able to equip not only the teachers but also the students in the private schools in Nairobi. And the plan is to also get out of Nairobi so they know what to do in a case where you have a disaster. So it's a step by step. We started the help of professionals in the private hospitals, moving to the public hospitals. And now we want to go into the schools because we know that children can be taught how to respond. And when they are not taught on what to do, then the casualty level becomes very high. Yeah. So we have had 3 trainings, as you have seen, over the years, at least each year. This year we'll have one possibly in October, November. And we're hoping that this can continue and have more and more representatives coming here and being able to meet other colleagues in other countries, Israel and the rest, to get more skills the same. Yeah. Thank you.
So I guess we still have a bit of time. We could take some questions. In case there's anything that you'd like to know and we don't know, of course, all of our colleagues are on standby, the senior colleagues who have a lot of institutional history for KPA. We can always get in touch and give you the feedback.
Yes, I was just curious. You mentioned the number of physicians you have participating in KPA. What percentage of all of Kenya's pediatricians is that? Is that a small percentage? I don't have a sense for.
So roughly around 500 is the number of all the pediatricians.
Okay.
Yes.
Okay. I wasn't sure what that.
So generally we try to get everybody involved in KPA. Yeah, but like I said, not all paid up members.
Sorry to cut you short. So my question goes in the same light with the number of pediatricians to the population. So we mentioned 50 million people to 500. That is a very negligible number. What is the...
It's worse.
I mean, I've worked in Africa, I do know. I'm just saying, this is a great organization. I heard your presentation is excellent. And what is your, any action towards that in kind of, as the KPA, fostering more pediatrician? Like, what is the incentive, encouraging medical students and pushing them to be more pediatrician to kind of close that gap? Is there any work in that light at all?
So I would say of all the disciplines, in terms of mentorship, the pediatricians are one of the more approachable bunches. So we have now 8 medical schools that are available, and they teach pediatrics, of course, in all of the institutions. So as KPA, what we're trying to do is, especially like through our CMEs and things like that, is to provide a forum where they can get that pediatric knowledge, but it also provides them a network for networking. I mean, to be able to network. And we have these mentorship programs, although most of the time the mentorship programs were for between pediatricians, so like pediatricians with a certain specialization, then they go and mentor people in their facilities, in the different facilities. But I think it's something that we probably need to look into more. Yeah. But generally, we are getting like, how many? Like 1,000 medical students, 1,000 doctors are graduating every year.
Yeah.
So it is growing.
As Jason had mentioned, the pool of instructors in the ETAC class, which is a good example of how we can mobilize different levels of health personnel to be able to capacity build. What he did mention is that it's not only in Kenya, but KPA has been instrumental in the regional training and capacity building. So through some of the online programs, we are hoping that health personnel at different levels can be able to gain skills, and that has helped us utilize funds better. So both in ETAT and also in the disaster course. So we are hoping that even in the very remote areas, you can have the personnel who are there go through the online courses, and then you take them through a one-day practical session, and then even as they go through the online courses, like you saw the Maasai with the laptop here. So at least we have also Facebook coming in with free Wi-Fi, and be able to reach them, be able to go through that, and then for you to get to them and do the practical course would be much less, as opposed to before where you have a 2-week training and get a whole bunch of instructors down. That was not sustainable. So that has helped.
Yes, so I think we have 2 universities offering master's program in pediatrics. There are 3 now. Oh yeah, there's 2 public, 1 private. Because I'm near the University of Nairobi, the class has always been getting bigger for the pediatrics. And okay, the trend I've noticed is that the number of men in pediatrics has been reducing. So, but you always have, I think they now have to do an entry exam, which was not the case because of the huge number. They are taking almost a third of the applications, because the class is now like you have more than 90 applications. So they have to sit an exam.
So we're graduating around 40 pediatricians, maybe a bit more every year.
So now we love now maybe going to the NGOs, and yeah, so still is need for a bigger number.
Sorry, I've got around, but I have a quick question. What has happened to Mike English is, Mike was doing a quality assurance with the KPA.
So we still work very closely with Mike.
No, I know, but he's done some pioneering work on quality of care, right? The basic training. So are you rolling it out through Kenya?
As a training?
Not training, it's the quality, right? It's the quality of how do you manage meningitis, how do you manage pneumonia, how do you manage. So Mike did a lot of that. I mean, quite pioneering. He did it, and he started with it. And I wonder how you're rolling it out.
So they're still doing a lot of work.
Yeah, because I started working with Mike English, who is one of the directors of the Handbook, the Kenya Medical Research Institute. The guidelines are the work they were doing was converted into the pediatric guidelines. So now the guidelines, now we broke it down to a training program. So that's what I ran, the training program. And yeah, so it's research guideline training. So it's continuous. Yeah, so it's still going on, and their work really informs a lot on what we do in terms of research guidelines and trainings.
Could you comment about this?
So there's it's now still part of the research. It's called clinical information network. So they just put in different hospitals with targets on different standards of quality of care.
Yeah.
So then the hospitals like compete within themselves and they get feedback on a regular basis.
So he's introduced that.
Yes,
That was Claudia Lamata's initiative.
And then they have found out
so that's good as indicated. So
they have found out that just feedback only without any resource input also greatly improves quality of care. So they just come, they give you the guidelines, and they keep checking what you're doing and giving you feedback. So and the hospitals that get feedback, it was randomized. So the hospitals randomized to just get feedback and guidelines did better than the hospitals which only got the guidelines. So just feedback without any other additional resources. Just that your assessment of dehydration, there are gaps, you need to do something. So then your dosages are wrong, then you need to do something. So without any other extra input. So such work also now informs even the way we deliver trainings, that we have to plan to keep checking the things that we teaching.
So I'm just wondering, in the U.S., a lot of kids really are taken care of by non-pediatricians. So when we do our rural outreach teaching, it's even one sick child can be overwhelming to a small clinic. So part of when we do outreach, it's addressing the supplies, the training of people who have not had pediatric training. Is this similar in Kenya? And if so, does KP kind of extend this training to non-pediatric providers, given the numbers that you kind of mentioned earlier about the number of pediatricians?
Yes, so generally, maybe Kiruja should comment more, but we have clinical officers, we have nurses being trained, and medical officers. So nobody specifically in pediatric training, and in those hospitals, usually they rotate through each department, so they're not specifically for pediatrics.
Yes. What we're encouraging the hospitals now to do is to have people, like even if you're a medical officer or a clinical officer, to be assigned, someone to be assigned to be, who has interest in taking care of children, to be assigned to be, because usually people rotate on a very random way. So we are encouraging the hospital to have someone nominated to be taking care of the children. And then we can be sending that person to trainings and also providing them with the guidelines. So that has helped a bit, because as we had there 500 and maybe more than 50% of them are in Nairobi. So there are counties, so there are counties without any pediatrician. Yes, and I've been to some of those counties, and that's what we're encouraging them to do.
Maybe I would just add, they're not hyping their basic pediatric protocols as well as they can be. I mean, they save lives. When I worked in Kenya, I carried it in my pocket and I trained interns, and literally standing at the bedside of a seizing child, open up your protocol to section on seizing. What's the dose? What's glucose? What's next? And people use them, and I mean, we literally saved lives on the wards using these adapted protocols and the training that people got. They were amazing. And if you go to another country in Sub-Saharan Africa or other places, I would download them because they're adapted from the WHO guidelines, and maybe the drugs are a little different, but they will teach you so much. I was left on a really rural hospital ward when the pediatrician said I had to go on vacation for a week. Here's the protocols. Do you mind? Not appropriate. We talked about that in the Global Health course. I literally went bed to bed with the nurses, asking them, first of all, what would you do? And then opening, malaria. Okay, step one, we do this. I mean, those protocols are like incredible in Kenya. They're mini pediatricians in a box. Yeah.
We will share the resource with more.
Yeah, just to mention, we've shared the guideline with different countries. When you go to Rwanda, the only difference with the Kenyan guideline will be the cover page. Yeah. So I was in Myanmar early in the year, and they also adopted the guidelines, and then they added a few things about dengue and snake bites. So, yeah. So we've been to several countries.
I think we have time for a half a question.
I have a half a question. We work in the Kisi Namira area and with community health workers and nurses there, the dispensary nurse. Do they have access to these protocols?
Yes.
That's half a question.
So there's a link, you can download it onto your phone, and then we also have printed hard copies which we're able to distribute. Yeah, so we'll share those links. I also wanted for the people who are doing the course for global health, you can have a look at our pediatric guidelines for tuberculosis. I think in terms of identifying what